conference will now be recorded.
Jonathan remembered to hit the record button, so that is good. Our GoToMeeting application has updated, so we do ask if you can please have your camera on as we'll be doing votes. Secondly, Jonathan has captured most of your names as you have logged on, but I am going to ask him to do a roll call vote so everybody knows who is on the line, because we can no longer change the names. So they show as caller 00 and caller 01. So Jonathan, if you could do that.
Yep. So Justin, I'm going to say your last name's wrong, and I apologize. Justin Botla?
Yes, I'm here.
All right. Paul Barter?
Yeah, I'm here.
Bob Bowman? Not here. Melissa Brooke?
I'm here.
Dr. Coates?
Yeah, I'm here.
Dr. Delaney?
Here.
Brian Draper? Dr. Heiss? Dr. Holliday?
Here.
Dr. Holland's excused. Dan, I got you already. Josh Levesque? Dr. Gray?
Here.
Robert McKenzie?
I'm here.
Dr. Maynard?
Here.
John Mitchell?
Here.
Bill Rice?
Here.
Debbie Singleton? I know Debbie's here. I saw her.
Yeah,
Dr.
here, and I
Sinster?
just was I was just texting Brian to see if he's joining.
Okay. Mark Tuttle? Okay. All yours, Ann.
Is that everybody?
Yep.
All right, I'm going to share my screen and we can stand for the Pledge of Allegiance. Maybe. There it goes. Everybody can see the flag.
We can't. Oh, yeah, now we can. Never mind.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Okay, let me undo the share. The minutes for the November 2021 meeting were sent out for review. Hopefully everybody had an opportunity to review those, and I would entertain a motion for their approval.
I'll make a motion to approve the November 1st, 2021 minutes.
Motion by Dr. Gray. Is there a second to that? Is there a second?
Second.
Okay, who seconded? I didn't catch your second. Okay, Dr. Holliday seconded that. Is there any further discussion, additions, deletions, or corrections on the minutes? Hearing none, if instead of doing a roll call vote, I'm going to ask if there is anybody opposed to approving the minutes as received. Speak up now if you are opposed. Hearing none, moving forward. And we'll do the DOH enforcements next. I will bring them up on the screen, and I apologize because this new platform is not sharing as quickly as the old one used to. There they are. Sorry, I have 1,500 files open on the bottom of my computer, and I lost that one. They're opening. I apologize. I had them all open already, and that one disappeared. As soon as the file opens, you'll be able to see it. Apparently my computer doesn't like having the GoToMeeting up and running along with all the rest of them. Jonathan, they're not. I had them open on the screen. Do you want to try on yours? They will not open here. Oh, there we are. And now I was click happy, so they're going to open 100 times. All right. Well, that's kind of waiting there, so it's sitting and spinning here. And it didn't open. There we go. All right, let's get this into a view you can see. Debbie, do you want to read those, or do you want me to go through them?
I wasn't going to read them. I thought we could have the minutes reflect that they were shared with everybody, and that we had some people that were concerned at our last meeting because there were so many of them and how long it took to read them. So I thought we could try doing it like this and then attach that to the minutes.
I just want to make sure that we're meeting what we're supposed to.
Yeah, it says they have to be shared. As should be read into the minutes of your next regularly scheduled meeting. So.
All right, well, everybody's had a few minutes to look over them. Are there any questions? And I apologize, I keep making them smaller, but that's the full list. So there are quite a few of them.
There's some more at the bottom, Ann. They're not all showing. It's only going through 11:3.
Oh.
If this isn't how people
Yep.
want it, I have printed. We can read them if that's better.
Yeah. No, but I don't know why they're not all showing, because on my screen they are now. 10:25 to 12:27. This link is what?
I can see the full list.
Okay. Any questions on those? All right, so moving on, I don't have any additional correspondence other than stuff that we'll cover during the meeting. Does anybody else have any correspondence? All right, so state EMS meetings. Mark Devers is not on, and
He's with Melissa.
Oh, are you there with Melissa, Mark? Would you like to give a report?
Yeah, he's here.
Yeah, sure. So we met on January 22nd. There's changes to the viral pandemic protocol that have been sent to the commissioner. Basically, they made it more generic instead of just COVID. They made it generic for future pandemics. It does leave up to the REMAC whether or not medical control will be required for provider-initiated RMAs, and there are some pediatric issues that they're working out. The other big thing is that they want it to be reapproved by the REMAC every 14 days. So at some point in time, the REMAC's going to need to develop a policy on how to implement and renew this policy. Also on how to make decisions on whether or not you want medical control for provider-initiated RMAs. They're working on, there's a pilot going on for Suboxone in a pre-hospital setting that has been approved. And there was a lot of conversation on the difference between a protocol and a policy. The way Division of Legal Affairs has interpreted it is that the REMACs cannot adjust a protocol. They can write policy, but they cannot change a protocol. So what they're actually going to decide as a protocol versus a policy is still to come. They seemed to be pretty in favor of the regions and the REMAC still having influence and authority over it. This is a state decision that decided that a REMAC could not adjust the protocol. And it was, the biggest one of controversy was a Rochester area one, where in refractory VTAC VFib, they wanted to limit the epi to 3 and transport to an ECMO-capable facility in certain circumstances. And DLA has considered that a protocol. CMAC very quickly approved the policy or the change. They just had a long conversation on what the difference was. Moving into the future, it looks like healthcare proxies are going to be applied to out-of-hospital work or pre-hospital stuff in a limited amount. There was some really good numbers presented on an RSI study out of Suffolk County, where they had a really high success rate, and the medications that they used. I'll send that PowerPoint out to Jonathan. And the only other thing that's kind of note is the state did pulled some data out of their system. There's 70,000 EMS providers certified in New York State. There's between 30 and 35,000 of them that are not actively providing care currently, meaning that in 2021 they did not appear on a PCR. So, you know, the staffing struggles, as I hope we're all aware, are not isolated to the North Country. They are state and nationwide. So unless anybody has any questions, I don't have anything further to report.
Jonathan, would you be able to send the PowerPoint on the Suffolk study? I'd love to see what made them successful, like maybe it's technique.
Yep, I'll do that as soon as Mark gets it to me.
Awesome. Thanks, Mark.
No problem.
Are there any other questions for Mark? As you can see on the agenda, I do have the viral triage protocol at the bottom for discussion that he discussed.
Is this where we should discuss the budget and the proposed changes in that, or do you want to do that under new business?
That would be
is
under
up-
other new business,
Okay.
if that's all right. I don't care.
I just shot that to you and John.
So is this, thank you very much. Is this viral pandemic triage protocol already in place and we're voting to use it, or is it still a work in progress, work in progress?
It was approved by the CMAC in SEMSCO
Mhm.
and is awaiting the commissioner's signature. We have protocols that were approved probably 18 to 24 months ago that are still waiting on a commissioner's signature. They promise that they're attempting to streamline the process, but it is New York State.
Okay. So you're raising it today so that we agree as a group to develop a policy that when we activate this, there's something like a process that needs to be done, approval of REMAC?
Correct. So there's a requirement in it that one, the REMAC defines whether or not medical control is going to be required for provider-initiated refusals. In other words, I walk up to you and say, you're really not sick enough to go to the hospital, take 2 Tylenol and call me in the morning kind of thing. And it has to be renewed every 14 days by the REMAC.
Mhm.
So is that something that you just want to give Dr. Delaney or her designee power to do? Is it something you want to form a special committee on to meet? You know, like New York City, for example, has a very large, well-funded REMAC. They have an executive committee that it sounds like they're planning on passing that off to. In our case, it's quite a bit different, where most of you are not funded to be part of this. You're not well compensated medical directors from FDNY, so it may make more sense to look at a little bit more streamlined approach at it.
So the plan was to have that discussion on if it does get approved before our next meeting, kind of what the thought process was. So I sent it out with the meeting notice so folks would have a chance to look at it and formulate questions that we can either pass on or, develop a process when we get down to new business.
So I guess number one, I'll start. I am in favor of contacting med control with this new protocol. I'd like to get the feel myself, for my comfort level. That could be changed in the future. And then what works really efficiently, I feel, Anne, is from a medical director perspective. If we ever activate this, if you send an email asking for a vote, we live in different areas. It's not easy to get together to discuss. Those are my 2 recommendations.
Okay. All right. If you don't mind, if we go through the agenda and then we'll come back to that under new business. Okay. Is everybody okay with that? Anybody opposed? All right. RSI testing. Is there anything new on that, Mark? Okay. The next item on the agenda is protocols, and Mark kind of already touched on that. The protocols that were previously approved, along with the viral triage protocol, have not come off the commissioner's desk back to us as of yet. So we'll keep that on as other old business awaiting their approval and our notification. Difficult airway, I don't think there's anything new on that. Debbie, do you have anything new? Okay. So the VERSID committee had been
They're
formed.
waiting for us to have a class. Sorry, they're waiting for us to be able to have a class.
Okay. So the VERSID committee was put together to look at the administration of VERSID, specifically with behavioral patients. At the last REMAC meeting, it was approved to move forward with the quality corner that was developed by the committee, and that was published and posted on our website. And that committee is moving on to look at trauma scene times for our next educational quality corner, which will come to this body for review prior to being published on the website. The data committee, we continue to move forward. I'll talk a little bit more about that in my report. And next on the agenda is the CME manual changes. So the CME manual was sent out to everybody. And basically those changes just reflect a change of the word suspension to non-credentialed. Did anybody have any questions? Have a chance to review that, and do they have any questions on that? All right, it just took me a minute to bring that up on the screen. Don't look at it for a minute. I'm going to make you dizzy. But the changes, I believe the first one was right here. As you can see, suspensions was removed and it was changed to non-credentialed. So again here, the word suspension removed for non-credentialed. And I just reconfirmed what we discussed at our last meeting, that providers that were previously inactive, that their skills demonstrations be done at a scheduled agency CME session. And then again, the suspended was changed to non-credentialed. And again, and I do believe that was it for the changes in the manual. There's any discussions on that? We will need to approve this as a body. So I would entertain a motion for approval.
I make a motion to approve the changes as stated.
Thank you, Dr. Gray. Do I have a second to that?
This is Dr. Maynard. I'll second.
Okay, I have a second by Dr. Maynard. Is there any further discussion on this matter? Hearing none, if anybody is opposed, please speak up. And if I don't hear from anybody, I'll assume that it is approved. Okay, sounds like it's approved. Thank you. We're going to have a super short meeting here. So let's go into the program agency report. And share my screen. Oh, and I just lost all of you. I can't see you any longer because it shared the wrong screen. Hold on a minute, it shared, so it covered over, it shared on the wrong screen. In this minute, I have to move you guys over and then share it again. Sorry. Let's see if it'll work this time. There we go. Holy moly. All right, everybody see that okay? All right. My apologies. I don't know why this is being so slow to load up tonight. All right. So I attended the RTAC on December 10th. They did discuss that their trauma telemedicine program was discontinued. Patty Riley is the new State Trauma Advisory Committee representative at the state level. And they did a great educational review on actually the hospital MCI procedures post-summer bus incident with multiple patients off of I-90. So that was or off the thruway. But one of the issues discussed was the notification of other regional hospitals who may get patients or have capacity for patients, which brought up the discussion of EM resource as a potential solution to this need. So something for the region to consider in disaster planning or MCI planning is having the capability of notifying all the hospitals simultaneously and understanding what bed capacities are available in the event of an MCI. So, the Stroke Advisory Committee met on December 17th. SUNY Upstate is utilizing Tenectaplace in place of Alteplase. And they did provide a lot of information if any facility is interested in moving towards that. It is it's an off-label use, I do believe, so there are ways to go about using it. It has been very successful, and it's a bolus dose only, shows significant cost savings, and simplifies the transport of patients. So the education for EMS, I did ask them if there was additional education needed, and they said that things to monitor during transport are the same for Tenectaplace as they are for Alteplase. So we did send out for the July to October stroke feedback to the following agencies. We were working with Michelle to be able so they could send them directly, but what happens is we get a lot of changes of our CQI people, so it's really hard to keep that list up to date. So we've been helping them out with that. So working with the Upstate Stroke Quality Group, we did develop a second educational video as a follow-up to the first FAST ED video. And we are looking to do the incentives as we did before for agencies and providing them with a FAST ED stroke scoring tool. We're talking about laminating it so they could have it in the back of the ambulance and use dry erase markers on it if they wanted. One of the other regions did that, and that was really well received. So we're working on seeing if we have the ability to get those made. This is like a 5-minute video, so do you guys want to see it, or do you want us to just send it out?
Send it.
Okay. All right, so moving on. These are all the agency renewals that have come through, and one ALSFR, the rest are transport agencies through the Tri-County area. So a medical director changes. So the first change will be Great Bend Fire Department first responders to Dr. Gray as their medical director. Jonathan, do you remember who their medical director was before?
It was Dr. Brown, who's been gone for quite some time.
Yeah. So I'd entertain a motion for approval of Dr. Gray as Great Bend's Fire Department Medical Director.
This is Dr. Maynard. I'll make the motion.
Motion from Dr. Maynard. Is there a second?
This is Dr. Delaney. I'll second.
Seconded by Dr. Delaney. If anybody is opposed, speak now. Otherwise, we'll consider that approved. The next medical director change is Norfolk Rescue had Dr. Heiss as a medical director. Dr. Heiss has indicated that she is going to be retiring. My understanding is she is going to be moving out of the area soon. So we've been working over the past year to try and get all of her agencies transitioned to a new medical director. So Norfolk Rescue will be to Dr. Howland. They have submitted all the paperwork. Entertain a motion for that.
No talking. Make a motion to approve Dr. Howland for Norfolk.
Okay, I have a motion by Dr. Gray
And this is Dr. Maynard. I'll second.
and a second from Dr. Maynard. If anybody's opposed, please speak now. Hearing no opposition, we'll consider that approved. And the last one is Star Lake to Dr. Delaney. So Dr. Sneisser was their medical director. I also was told he was going to be moving out of the area, and if I've not heard from him, I'm not sure what his status is, but so I would entertain a motion for Star Lake to be changed to Dr. Delaney.
This is Dr. Maynard. I'll make the motion.
Thank you. And a second?
I'll second it. Maria Gray.
Hello? Ann?
Yes, there. Is that Dr. Sneisser?
Yes, it is. I apologize about that.
I was just asking about you.
I was out and I got a little stuck at going out and doing something, and then I just got in and I realized the REMAC meeting was on.
All right.
And I just heard. What was the reasoning for it? I'm just wondering. I don't mind it, but what was the reasoning for it?
So they submitted their paperwork to us.
Oh, the hospital or the REMAC, the EMS?
Star Lake had submitted the paperwork to change to Dr. Delaney as their medical director.
That's fine. Are we talking about the other places I'm medical director of being going to somebody else too, by any chance?
Well, no, I had just said that I had spoke with you previously when I saw you, and you had kind of indicated that you were going to be moving out of the area. I wasn't
yes,
sure.
I
if
am.
that
I
was
am.
still the
No, I
case.
am going to be moving probably in June or so, but that's fine. I just wanted to know
Okay.
what the story was. I apologize. I hopped in a little bit late and everything.
That's
else.
okay. That's what the discussion was. We were wondering if you had moved or if you were still planning on.
Yeah, I missed the last one, and I set a thing on my on my whiteboard for the meeting this week, and then I was out in my car doing something, and then got back and realized I had the meeting. So I apologize about being late.
All right, no problem. Thank you.
Thank you.
So,
Congratulations, Dr. Delaney.
I apologize. Where was I with that? Did we have a motion yet for that one?
We're good to go.
A motion, okay. All set. All right. So agency upgrade, we received all the paperwork for Rensselaer Volunteer Rescue Squad to upgrade to critical care level to paramedic. They have a new paramedic provider. By upgrading, it will assist them with some revenue recovery. Any discussion on this? It would be pending inspection by the program agency that they get the additional paramedic equipment. So I think they have, Jonathan, if I remember right from the paperwork, they don't have a lot of providers, but they're a small, low volume agency. They have one paramedic, a few BLS, and one AEMT, I do believe.
And is there any information that you're holding, that you're waiting for from them? Are they current on anything that you need? I know now that we have EPCRs, you're not waiting to get charged in, so that's not an issue, but are they current on the other stuff that you need?
Yep, they're pretty responsive anytime we need anything. So they included their meeting minutes, where the agency itself, they have the appropriate paperwork all submitted. So Dr. Howland is their medical director.
Do you need a vote?
Yep.
Oh, okay. I make a motion to allow Rensselaer Volunteer Rescue Squad to transition from critical care level to paramedic pending inspection.
Thank you, Dr. Gray. Is there a second to that?
Second.
Second from Dr. Sneisser. If anybody's opposed, please speak now. Otherwise, we'll consider it approved. Hearing no opposition, we'll move on. It's an update on public access defibrillation. Again, Great Bend resubmitted their paperwork with the medical director change already. And then the YMC and Morgan Stanley updated theirs. So regional BLS adjuncts, we do have a request for Defibrillation Fire Department first responders to do BLS albuterol and BLS blood glucometry. So I would entertain a motion for approval of that. Those two adjuncts for Defibrillation.
I make a motion to approve Defibrillation getting BLS albuterol and blood glucometry.
Thank you. Is there a second?
I second.
So second by Dr. Delaney. Anyone opposed to that? Hearing no opposition, we'll move on. So the health commerce system, I've shown this slide before, I just brought it back up. We still have 16 agencies who do not have representatives on HCS. I think some of those may have it through another agency, so they just haven't got their agency signed up with a representative. But we continue to remind them. And the corrections that were sent to the New York State Department of Health on our North Country EMS agency list has not been included. So we do have a few agencies, such as Henderson Fire Department, Carthage Fire Department, first responders, and there's another list of them that are not even in the HCS listed under the North Country because they're either a newer, well, Henderson, I don't know why. The rest of them are either a change in agency code or a newer BLSFR that are not in there. So I'm not sure what the state's plan is on updating that. But again, I think the bigger reminder, and we've done a few of them, is that as agency leadership changes, they need to update our office so we can either get a new representative into HCS or remove, whoever the representative was. So agencies need to remember to let us know. Whoops. So EPCR, we continue. We have another BLSFR going live. Everybody enrolled in the CME program to maintain that did get done except for Cme. And it does look like they are working with Jonathan to get that done. So along with the other ones that are bold, they're working on it as well. So the schematron for the electronic PCR was supposed to be updated on December 28th. There was a lot of concern with them choosing that date, but it was actually postponed due to the National Ambulance contract being activated. And we continue to work with agencies, software vendors, and everybody to resolve data issues. We're frequently finding our partners, especially in the trauma and the stroke programs, are requesting PCRs because they're not uploading correctly. So we continue to work with that in the agencies. So December 31st was the end of the semester for CMEs, both ALS and BLS. It took us a long time, again, post-COVID and our agencies just being so busy. We had to send a lot of reminders and a lot of requests to multiple agencies to make sure their providers were done or it was documented. And we actually had 17 ALS providers that received non-credentialed letters. 2 were informed us that they were no longer practicing at the ALS level, that they did, they're only going to practice at the BLS level. And then we had 47 BLS providers that had non-credentialed letters that would be unable to do the adjuncts. We also noted that there were 5 on medical leaves or other type of leave of absence from agencies, and we removed 38 providers from the system who were no longer with an agency that we're aware of. So that is our report for that. So Spring Fling is coming up the 28th through the 30th. We did discuss not doing the Sunday session, and actually the Thursday night session is up in the air. We're working out some details as to whether we're going to do the Thursday night, but we're definitely going to do Friday and Saturday, the BLS and the ALS core content, along with the day of lectures, ALS and BLS. So if any of our local physicians are interested in speaking on Saturday, the 30th, please send me an email. And the 2022 EMS Leadership Conference, we had 40 participants, 7 of which are from the North Country and are going to be attending virtually. And that's just an update. I reported that at the last meeting. Debbie, did you have anything more you wanted to add in on the Spring Fling?
I'm working with Janine Radley at Edgewood because the pricing came in for the meals, and we had made a conscious decision to make a couple changes to try to help keep the price down. And she's reworking the numbers, and I should have that this week. Letters were sent out to all of the hospitals in our Tri-County region, asking them to help support Spring Fling, asking them for a financial contribution so we can keep the rates down and continue to offer this for our providers. If anything comes in, it would go to the office, and I don't know if Jonathan, if you've seen anything yet, but we will be following up and phone calling hospitals and ask them to support this so we can continue to offer this for our volunteers.
Thanks, Abby. So EM Resource, we did get a preview of an update that will be coming, and it's actually a little more the system itself is pretty user friendly, but they made it even easier. So, and we're continuing to work on getting agencies within the system, and we haven't had an update as to where the state is with how they are launching or what platform or what the requirements from the state will be. when they launch EM Resource, but we're hoping to be able to integrate our system into theirs. So that slide was supposed to be hitting. I did that last time. So a recent email that I received is that a lot of the agency's renewals and narcotic renewals are coming in either last minute. So a correspondence was sent out to agencies along with 2 new checklists with the appropriate email addresses on them. Were sent out to the agencies and posted on our website. And that's just the next state EMS meetings are April 12th and 13th. I'm not sure how that's going to play into our next REMAC meeting because it actually falls before the state meetings. And then I'm sure that may be discussed at the REMSCO tonight, and we'll let you all know. And then the Ems Memorial, I believe initially it was reported at 9, but now I believe there are 10 folks that will be going up on the wall. That will be May 17th. Any questions for the program agency? I think there's only one thing that I just thought about now that I didn't put in there, but any BLS FRs that are currently in the CME program need to submit a vehicle registration through the portal for the new policy statement that came out. So that's something we'll be working on, ensuring we get correspondence out to the agencies. We've had a couple BLSFRs that have done that already, as we are copied on them. So that'll be something that we'll be working on. Any questions? Hearing none, we'll move on to new business. So drug shortages. We're hearing reports of lots of drug shortages as usual. Epi 1 in 1,000 has been in a shortage. And the question was brought up about having basics draw from ampules. They're not taught to do that. I did reach out to the state. I never did get an answer back, Debbie. As I told you, I had reached out to the state. So I'm not sure what this group's thought is on that, if we're unable to get vials of Epi 1 in 1,000 for BLS providers. I know that I've heard a few people voice some significant concerns over them utilizing an ampule. So I'm just looking for feedback.
Hey, Ann, it's Mike Bennett.
Yes.
Wasn't the original check and inject pilot done with ampules?
No, it was done with vials. Hence the reason why we didn't have
vials, that's
ampules.
correct.
Is it possible to have the agencies that are affected by this do their internal training and make their decision whether their comfort is there?
Yeah, we're not sure what the state's take on that is because it's a scope of practice thing. I don't know. It's one of those I didn't really know who to ask. I did reach out to the state, but again, I haven't. That was about what, a week and a half ago, Debbie, 2 weeks ago. Might have been more like 2 weeks ago, but I have not received anything back.
Yeah, it was 2 weeks ago. I did find some in the vials, but they're saying that what's out there is all that's going to be there for an indefinite amount of time, that the government is buying up all the 1 to 1,000 ampules and they're buying up all the 1 to 10,000s as well, that there's just not going to be any available for an indefinite amount of time. So that's why I'd reached out to Ann. thing here. So if we get a determination from the state and they say you could use it, that we know whether you docs are in favor of that, us putting a training program together, or if you just don't think it's a good idea.
This is Dr. Maynard. I think our BLS providers are fully capable of using an ampule if they're capable of using a vial.
I agree.
Dr. Holliday, thoughts?
I'd be in support of using an ampule instead of a vial as well. That's what we're left with.
All right, Dr. Coates? I believe I heard him say I agree. It was pretty faint. Dr. Sneisser?
The only quibble I might have is if make sure they have the specific needles with the filters in them when they draw up. But other than that, I don't see a problem with it.
Maya?
I agree. I support it.
Okay. So basically, I would say that our best course of action, if the REMAC is agreeable with it, is to follow it's actually an alternative medication policy, where even though we're not changing the medication, we'll go through the process, because I don't think it's a bad thing for them to get additional education on the medication, even though we're only going to change how they're actually drawing it. So they'll get a full review. And then we'll submit that to the state for approval. But I will
And I'll work together a training program that then you can send out to everybody and see if there's any input. I'll pull stuff from my advanced program.
All right, I do think I have, I'm not sure, I might have some part of that, so just get with me. But so we'll kind of follow that process, and then we can send it to the state and hopefully get ahead of this before it becomes a crisis. But I think one of the parts of that is we do need to kind of have an overview. But if people haven't ordered it yet, they don't know, they're not going to be able to get it. So we'll start working on that. Okay. Does anybody have any other issues with any drug shortages? Okay. So, moving on. We got to close a couple things here and see if this works better. Let's pull this up. So the next is the viral triage protocol that we talked about earlier. As soon as this comes up to share, I'll share it on the screen. Mark may be able to add Mark has already discussed most of this. If he may be able to add a little more to it. But basically, one of the discussions that I remember is that was a huge discussion over whether fever should remain in the protocol or not. Mark, I thought they got rid of it, but it looks like it's in this one that I pulled off, what I thought was the edited one. Do you know?
After the hour and a half of bickering on medical staff or medical standards, I don't actually remember what they came up with. I do know they tried to make it a little bit more generic, so it wasn't specific to COVID. And there was a lot of conversation on fever and what the fever should be. And the other big thing was pediatric heart rate or pediatric vitals.
So this is I pulled this off the email you sent, so that may not be the most updated version then, Mark.
I can look in a minute.
All right, but anyways, so once this is approved, I will reach out to all of you. So I guess basically at the state level, we just want to discuss the process. This protocol would have to be activated by the REMAC and then renewed. So Maya's already put that she would be in favor of an email vote. That certainly works for us. For me, does anybody else have any other discussion on it? As far as the notification, we'll talk about med control in a minute. Okay. So hearing no discussion, I'm going to assume that emailing the REMAC, so I guess my clarification would be specifically just the docs, the REMAC docs for approval to put this into play. And then the next one is contacting medical control for treat in place orders. So Maya's indicated she's in favor of that. How do the other folks feel about that?
Sounds good to me.
Okay. So I know that some of the areas had concerns that med control would be bombarded in some cases, but I'm not sure that's the case here.
I think that's going to be. I think that's going to be the key. Is we have to make sure that all the docs and the ED are aware of this. So when people call in, they understand why they're calling and don't say, "Why are you calling me?" and know what we're looking to do. So I don't know if once this comes out, we could laminate it so that the hospitals could have it next to the radio, but we have to make sure that they understand why people are calling in and that they're going to support them when they're calling in for this.
Absolutely.
This is Dr. Maynard. I agree with Dr. Gray. I think we should start at least with calling med control, and if we find it to be too overwhelming, we can revisit it later, but I think we should be aware.
Okay. All right. So at least we'll have a plan in place at the point that at such a time that if this is approved in between the meetings, since we don't meet again until April. So I appreciate that. So next on the list is the Indian River Ambulance Service. They did put in a request. So lactated ringers was taken out of the protocols. And they did put in a request to use lactated ringers. This, I actually received this request after, I don't remember when I got it, around 11/30/21, but we already had some of the discussion on whether things are a protocol or a policy. So I wasn't sure whether we should move forward. You know, we used to allow people based on submitting all the information, which this was sent out to everybody, to be approved for, you know, an alternate medication or so. I'm not sure what we want to do with this, whether we want to hold on it and wait until the state defines the difference between a protocol and a policy. So we don't have the same thing happen that happened to Monroe Livingston when we put something out. Or what is this group's thought?
Is that clarification, do you feel coming down the pipe soon?
I don't know the answer to that.
And it's Mark. To Maya's question, nobody has the answer because it's the state and DLA is involved. One of the options is to make it a regional option with medical director approval. and then submit it to the CMAC for approval. They did not bulk it at all at the proposal sent out by Monroe Livingston. It was, again, whether or not whether they were protocols or policies. So that might be an option. I don't see where this would be an issue getting approved.
I think that's very reasonable to go that approach.
Okay, so I'll work on putting it more into a regional policy type form. And then bring it back to the next meeting for approval.
It's Bob. I think that would be a wise idea. Maybe somebody can refresh my memory on this, but when we had a normal saline shortage, I believe that we regionally approved it based on the shortage. Perhaps we could find a old policy on that.
Yep, I will look. Okay. And I did have, so is everybody okay with that?
And it's up to the group, but CMAC meets before REMAC, and CMAC probably will not meet again till the fall. So I don't know if you guys want to do something through an email vote or not. It's up to you guys.
All right, I'll get it done and I'll send it out for an email vote unless somebody objects. Okay. And then last but not least, I don't have this on the agenda, but under other new business, back at a previous meeting, I had given you the stroke data that we had pulled from the EPCR system. So, whoops, sorry, let me just reference. So the first report I had previously given you was 6/1/2020 to 12/31/2020. This new report pulled the same exact data from 1/1/2021 to 7/30/2021 to do a cross-reference. We had 179 charts, which was a few more charts than we had in the previous grouping. But we did see an increase in charts not having a blood glucose documented. We saw an increase. Why am I echoing? Is everybody on mute? There we go.
You're good.
Okay. We did see an increase in 20 charts not having a stroke scale of any type recorded, and 19 charts indicated as transfer to a landing zone or aeromedical, which was actually a decrease. And then we did see, which was what we were looking for, an increase in the use of the FAST ED. So that was good. Some of, I believe, what is attributed to the increase in the other ones is, and we didn't go back in and look, some of them may have been intercepts where the ALS chart caught the blood glucose and the stroke scale documentation, and it wasn't documented in the BLSFR. So we would have to dive down a little deeper in that to see why the increase so much. But again, the weaknesses, landing zones are documented differently. We're hoping that that'll change moving forward. 4 charts did not even have a destination documented, and there's still, at this time period, were some outliers that weren't documenting electronically yet. But now, as we start to move forward, we have everybody documenting electronically. So, and of course we have data that's not uploaded that we may not know about yet, that we seem to find out as we go through, or we get reports on calls that haven't uploaded into the bridge. So, any questions on that follow-up data? It is nice that we're actually able to start looking at some of this stuff and hopefully starting to focus education a little more based on data. We are getting together things that we are noting through the data committee. And we are making educational PowerPoints. One of the things that we're truly waiting for is the state data dictionary. So we can ensure that whatever we're educating on, that is what the state is actually looking for in those fields. So, any questions on that? I would offer that if there's any information anybody wants to see, to please reach out to me and we can try and pull a report. And again, hopefully with the State Quality Metrics Committee, there'll be some standing reports that are made that agencies will have access to be able to see how they're doing in certain areas. So based on the quality metrics that are chosen. So that's all I have. Any other new business?
The budget, Ann,
Okay, go ahead.
if Mark wants to.
Sure, I always want to talk more on meetings. EMS was mentioned in the governor's budget for any length, and for the first time in forever, it's about 3 pages long. Ironically, they're not doing much with money. From a financial standpoint, in Medicaid, they're giving us back 1.5% that they took from us a couple years ago and doing a 1% increase, which still leaves us well short. What they are doing in the budget is rewriting large chunks of Article 30. And the concerning part is I think everybody is in agreement that Article 30 needs to be significantly updated. The problem is that it's referencing a state EMS plan that has not been written yet. So we're supposed to be making all these, Article 30 changes to who has various authority over things based off of a plan that literally does not exist. And it seems to move a lot of things towards CMAC as opposed to REMACs. And the version that is currently readily available actually gives CMAC statutory authority over EMS as opposed to SEMSCO, because it's not well constructed. So there's a huge amount of question going on with it. And I guess if anybody has any questions, I will try my best to answer them.
Mark, there's a lot of background noise there. It's kind of hard to hear you. I don't know what's going on, but there's a lot of background noise. So do you want to give people the status of what it looks like with REMSCO and REMAX, just what we know as of right now based on the budget?
So the way I would interpret it, and the way that it's generally interpreted, things like CONs will not be a REMSCO function, they will be a SEMSCO function. There's a lot of things. I struggle to find a place for a REMAC in this budget. Again, there were a lot of typos on top of it not making a ton of sense because of typos. So it sounds like they want to move all things protocols to the state. According to the bureau director, the intent of this is to force FDNY to get on the collaborative protocols. I have a lot of heartburn with not having regional input. There's some pretty smart docs on CMAC. However, most of them have never been north of the thruway. You know, there's definitely a myth that you can't take trauma patients in upstate New York to trauma centers all the time because it's a very long drive. They cannot wrap their mind around that in a lot of cases. So it really seems to push a lot of the power to Albany, and really pulls a lot of the power away from the REMACs and REMSCOs, through a not clearly defined plan.
I think that's the biggest concern with all the information that they have in the budget is it doesn't make a whole lot of sense, as Mark said. And it's just unclear of really what their expectations are or what they're looking for.
The 30-day amendment, oops, sorry, Maya.
No, go ahead.
The 30-day amendment period ends the 17th. Mark Philippi, who's a SEMSCO chair, has talked to Ryan as well as the various advocacy groups. And Ryan claimed that he was going to push for some changes to it. However, apparently once stuff is actually in the executive budget, it does not change very well. They're hoping to get the proper use of the term CMAC and SEMSCO changed, but we're not even sure that that's going to happen.
Do you need our region to write a letter of support, like for the region? And if so, if someone can draft it, because I don't necessarily understand your language, but if you need, you know, our support, let us know. Like, will that make a difference?
It could, because it's got to be approved by legislature. You know, at this moment, the best thing we can do is wait till the 30-day amendments come out and then see what changes were made and comment on them. I do know Jeff Call is testifying in front of the Senate Health Committee tomorrow on the changes, but again, it's very difficult to even give an opinion when there's so many typos.
So when you get that document, you'd be able to pass it forward, the 30-day amendment one?
I would love to, but yes, a letter from this body would help if to be forwarded out to elected officials who are voting on the budget.
It's difficult sometimes to come up with that letter. Again, maybe it'll be better after we have the 30-day amendments, because it's not clear what they're doing. I mean,
it's not clear at all.
What do you write? We don't have a clue what you're doing, so we don't support this. You know what I'm saying? I don't even know what to put in the letter. You know,
I know I know the stance that currently Onion and Nicevara are taking is more or less that you're writing something based off of a plan that doesn't exist, and really the budget is not a great place for legislative changes. It should go through the traditional processes so that stakeholders can be involved. But again, we're fighting something that we have no idea what we're fighting.
You know, I mean, because there are some good things, you know, if we're able to do, if it allows us to do community paramedicine or mobile integrated healthcare. it does kind of talk about that. Being part of the quality metrics tag, I know what the tags initiative is, and it's not punitive in any nature to any agency, because that's not what quality assurance is about. But there are many that question the way that it's written as to whether that is going to give the state power to, do punitive action on agencies that are not making these, are not performing to whatever standard that they make. Excuse me. Or are they just allowing it to be available?
It definitely opens a door for significant punitive action, depending on how it's interpreted. And again, it's really, really difficult to figure out because there's not a clean copy of it that you can actually read and figure out what it's trying to say. And I will tell you that there's some position papers out there that are pretty appropriate that I would be more than happy to forward out for people to view, and get an idea of, because again, we're opposing something that we really, really, really have no idea what it's actually saying.
Yep. Our processes are no longer clear for almost everything. Any other discussion on that? Now that I got my voice back, I apologize for that. All right, any other new business?
Yeah, I just wanted to make sure everyone on this call realized that Lake Netta, New York is now carrying blood products. So Colleen Gleason had provided some written literature. If anyone has any questions, they can reach out to myself or Colleen. I do know Watertown, Seneca Falls has it, and Potsdam will be getting it soon. So thank you.
So thank you. And for some reason, I don't know why we don't have Air Medical on this agenda, but we have it on the REMSCO agenda. It probably should be on this agenda. I will ensure that I get that added. So is Colleen on? Does she have anything else that she wants to report? I apologize.
Actually, I sent the report over to Jonathan and CC'd you, so if you wanted to put that in the notes, that's wonderful. And I also included the 2 flyers for the blood products that we're going to be carrying in flight. We currently have 2 units of O negative and 1 unit of FFP.
And actually, I did have something else that I wrote down that I needed to bring up. So we did send those reports out. So everybody should receive those in the email. We sent them out earlier today. The other thing I wanted to discuss, and it kind of goes back to the CME credentialing manual, and I had actually forgot about it till just now. But we have a few flight medics that also are ground medics as well. They'll work on the ambulance sometime, or they may volunteer for a local agency as well. One of the things that they don't always have time to get to an agency to do their regional CMEs, as we require them to be done. But my understanding, and I know LifeNet's training programs, and that I am wondering if there is the ability to allow the medical directors for the program to submit that they have completed the CMEs as required just based on their extensive training. And I'm pretty sure Mercy Flight does the same thing, but I would have to default to their medical director to ask that. So what are the folks' thoughts on that? Accepting the air medical CMEs versus they are way above and beyond the regional CMEs.
I would be in support.
I agree as well.
Okay. Does anybody else have any concerns over that? All right. So I guess that probably should be a motion to entertain any current flight medic within good standing within their organization CMEs in lieu of the regional CMEs.
This is Sarah. I'll make that motion.
Okay, so I have a motion from Sarah. Is there a second?
I second.
Thank you, Dr. Gray. Any further discussion? Hearing no, is anybody opposed to this? Hearing no opposition? Approved. Any other new business? Hearing none, I'd entertain a motion for adjournment.
I make a motion to adjourn. Thank you.
Thank you. Is there a second?
Second.
All right. Everybody have a good night and thank you.